thank you all for joining us today. We're having this discussion on osteoarthritis by Dr. Colin Gundling of Alliance Physical Therapy. We'll be having a question and answer session at the end of the program. You can ask questions in the chat, or you can unmute yourself to just ask them yourself once that has opened up. With that, I think I will hand things off to Dr. Gundling.
All right. Well, thanks a lot, Corey. Thanks a lot again for having me. This has become a more regular thing, so that's really exciting. Looks like we have more participants than we have in the past. So I don't know if the arthritis topic is a popular one for people or what, but it's exciting to see a lot more people here. So I'll kind of recap the reasons why we started doing this series and kind of what my goals are with it. So I'm a doctor of physical therapy. I practice in I practice in Murraysville for Alliance Physical Therapy. We have this practice and then one in Penn Hills. So we're just a small physical therapist-owned private practice. And our primary goal as physical therapists is to just help people move better and help them optimize what they can do through their daily life. And at Alliance, we pride ourselves in being persistent with that goal and in trying to help people really truly get there to the best of their body's ability. So our focus is to provide different types of care to patients, maybe some approaches that people haven't seen before, and really try to be persistent about it. So the main reason to do this series was because oftentimes I find myself explaining the same thing to patients over and over again. Not that I don't mind that, but there are common trends that I see in the common knowledge that we have about our bodies that need some updating, I guess I would say. The general population needs to gain a little bit of a better understanding about how their body operates. And there's some misconceptions that I see that I think the general public would benefit from having explained to them. So this series was kind of born of that idea. And it was over the course of the last, I guess, couple of years at this point, Corey and I have gotten together to expand that into different areas. And this topic today specifically is on osteoarthritis, and actually the lower body osteoarthritis, because that is one of the most common form. Other topics that we've had have included exercise, principles, balance is a big topic that I talk about a lot. Gaining a better understanding of the medical model as it pertains to orthopedic concerns as well. So we've been lucky to go through a lot of different topics. I think our next one will be on osteoporosis, which is basically a reduction in the bone mineral density of our bones that predisposes us to fractures. So I struggled a little bit with the title for this one. It's a little bit ominous, but hopefully I can explain my way through it. So the misunderstood, the uncurable, and the inevitable with lower body arthritis. And I struggled with it because I didn't want it to come off as hopeless, but I also wanted it to have a little bit of a shock value because this is something that we oftentimes the medical model creates it as a big issue, which it is, but it doesn't always have to be, and it depends on how far down the line of osteoarthritis you are. So again, as a physical therapist, my primary goal here is to promote activity that optimizes function. And there's some people that have end-stage arthritic changes that we're not going to truly have a significant enough positive influence on their function in physical therapy to prevent like a joint replacement surgery. But there are plenty of people below that level of arthritic change that can benefit significantly from extra mobility and extra strength in and around the joint. So there's different approaches and different principles that I want to talk through today of how to do that. But the first thing that we need to understand is that osteoarthritis is a specific form of arthritis. So we have rheumatoid arthritis, psoriatic arthritis, a lot of different types of arthritis. Osteoarthritis is the most common form, and it affects specific joints. So it's an inflammatory response in a specific joint, in the cartilage of the joint, resulting in a breakdown of that cartilage. It's while you can have arthritis in your knee and your hip and your back, it's not always a full system condition. It's not everywhere. Whereas like something like rheumatoid arthritis is considered to be kind of more of a systemic condition. So once you have it in one joint, it's going to kind of progress to those others. Osteoarthritis is a little bit more specific to joints, and it can be based on genetics, it can be based on wear and tear, it can be based on a few different things, but super important to understand that this is not just simply a wear and tear condition. So if it is, then it would be more like a tire, right? So a new tire over on that left-hand side and a worn out tire on that right-hand side. It's not the same as a new joint on that left-hand side and a worn out joint on that right-hand side. The reason that it's not the same is because our body can heal itself. And if it couldn't, we would be in all kinds of trouble. So our body, including our cartilage tissue, has the ability to heal. In fact, cartilage tissue in healing becomes healthier oftentimes because that brings more blood flow through it, brings more fluid and nutrient flow into the cartilage tissue, and which can cause things to be healthier and promote wellness in that tissue. So thankfully, osteoarthritis is not a simple wear and tear condition. Now, what does behave a little bit more like these tires would be a replaced joint, because really a replaced joint is just metal and plastic. So there's no regenerative potential in metal and plastic. So I'm not saying that you shouldn't get a replaced joint if you're in enough pain and struggling enough. Absolutely, they can be lifesavers for people, but just understand that you want to try to put that off a while because you only get so many miles out of those. Whereas they're never as good as the original parts. So the original parts do have that potential. Even if you have something like this over here on the right with those red arrows and that loss of joint space, even if you have that, there's still some cartilage in there. So depending on how symptomatic this individual is with that presentation on X-ray, it might be worth continuing to just survive and strengthen other muscles and use other joints and try to minimize the pressure through that knee as much as possible, because we want to wait till the last possible moment to have that replacement done. Now, the other side of that coin is that typically people are getting replacements as they get older. So if you're young and you're considering a replacement, you want to try to push it as far as you can. The other side of that coin, though, is if you're older and you know that knee's been an issue for a while and your ability to get around is declining and you're worried about your strength and you're worried about your ability to bounce back from a surgery, then that's a harder question to answer about whether or not to have that surgery, because as you start a functional decline, it might make sense to have that surgery, before that happens, so then you can optimize your health over again. Whereas if you have that surgery after that decline has been occurring for a while, it's going to be a lot harder to bounce back from that surgery. And unfortunately, we see quite often at post-total joint replacement surgeries that the function, basically the activity level of an individual, is lower than it was before the surgery, which is absolutely what we don't want. The whole intent of a new joint is to do more. But unfortunately, the trend oftentimes is that people end up doing less. So there's a problem there. There's a little bit of a disconnect there. And I'm not smart enough to know why, but I could hypothesize that it has to do with a lot of variables of being able to come back from the surgery in a healthy way, fully recover, fully rehabilitate. And in sports medicine, we see this quite often, especially when people have been injured once, they're always opened up to be injured again. So the biggest risk factor for an ankle sprain or another running injury is having a previous injury, having a previous ankle sprain, or having a previous injury while running. So is it because we have scar tissue there and things are injured, so that joint just isn't operating quite as well? Maybe, and that we might not be able to do anything to fix that. Or is it because they weren't fully rehabilitated appropriately? And I think that there's probably a little bit of both going on there. So all that to say that there's a lot of thought that can go into the decision to get a total joint replacement, and you want to preserve what you have. To further illustrate that non-wear and tear idea of arthritis, this was a study here. This picture of the runners. This was a study that was a systematic review of a lot of different randomized controlled trials about runners and their risk for arthritis. So basically you look at this as like a super study. We took all these other studies, took their data, put it in one study, tried to make it comparable, and then spit out some of this information. So if you see the percents down at the bottom is your risk for hip or knee arthritis, symptomatic hip or knee arthritis. So the recreational runner has a 3.5% risk for hip or knee arthritis. Recreational runner is defined as somewhere around like 10 to, I think 10 to 20 maybe miles per week of running. And this individual may still be doing races. They may still have weeks that go up above that 10 to 20. So that if they're training for a marathon, a typical marathon training is around 40 miles a week. And these individuals may be doing that, but it's just averaging out over the course of a year to be 10 to 20 miles. Versus the non-runner, which is 10.2% risk of lower body arthritis. So like I said earlier, we were talking about the fact that the cartilage has potential to heal in our joints. So as we work that cartilage, yes, it does become inflamed, but that inflammation process is then causes more fluid flow and more potential for healing in that joint, and then it heals, it gets better. And the joint cartilage in and of itself doesn't get a great blood flow. So if you're not moving at all, then there's not as much nutrient flow, because the nutrient flow comes from use. So if you're not moving at all, that actually increases your risk for arthritis versus a recreational runner. So that non-runner has a 10.2% risk. Now, what we often see in a lot of cases across our lives is that too much of a good thing can be bad, right? So too much running at this really high top tier level, competitive runner, is a 13.3% risk for arthritis. So that is definitely higher. And that's the reality of doing too much. Now, it's too much over a long period of time. So it's over like 15 years of running competitively, miles upwards of up beyond 55 to 120 miles a week, somewhere in that range. And that is where that up near 100 miles a week is where those truly like high top tier competitive runners are running. That's a lot. That's not going to give your joints that chance to recover, right? So we talk about inflammation is okay. And I've had talks about this in the past. If you guys have listened in, inflammation is a good thing. It's a natural body response because it brings more nutrient flow and blood flow and potential to build tissue health if you let it run its course and then re-irritate. But in these competitive runners cases, they're probably not giving it a chance to run its course and calm back down. So it's just constantly inflamed, constantly irritated. And that's where we can start to see some articular cartilage breakdown in those joints. So, I don't expect everyone here to be excited about running like I am, but what I expect you to get out of this idea is that it's not a typical wear and tear, and movement is helpful. So movement is lotion in this case, and it helps keep those joints moving and helps to keep them healthier. But too much can be a bad thing. So understanding the misunderstood. Remember my title up there. So the misunderstood is the fact that osteoarthritis is in fact a normal part of our aging process. So as we age, if we live long enough, we're going to end up getting arthritis in our joints. And it's not all because of wear and tear, which we'll talk in a little bit more detail in the next slide, although we already did talk about it. But it's really just part of the aging process. And the point of the aging process where it starts to occur has become earlier as our lifestyles have changed. So that's shown by a study that they did on 3 different eras of individuals. So the present day individual, they're talking about knee arthritis in these individuals. They took the present day individual versus the pre-industrial individual, so pre-industrial revolution, versus the prehistoric individual. And obviously they couldn't go back in time and study these people, but based on some findings of skeletal remains from those individuals, they were able to examine the joints and determine whether or not there was arthritis. Everybody in this study were over the age of 50 years old, and the present day individuals had a 16% occurrence of knee arthritis versus pre-industrial is 8 versus prehistoric is 6. So you could see that it's significantly lower than it is today. It was significantly lower than it is today. Now, you could say that people are living longer today, which is true. You could also say that people, but the other side of this coin is that people are way more than they did they weigh more today than they did then. So the body mass indexes are higher. So there's more stress on those joints. So when we control for people living longer, we still see an increase in occurrence of the arthritis in the joints, but it happens at different ages. So, at 50 years old, those people in the pre-industrial times and the prehistoric times had a much lower occurrence rate of arthritis. Arthritis is also often called the wear and tear disease. So we already talked about the running study that was done there. If we look down and we say that wear and tear, based on the fact that it's a wear and tear disease, someone that weighs more is going to tear up that joint more, wear that joint more. Because we think of it from a very mechanical point of view. Something that weighs more puts more force through something. But it's not the case. I mean, that's part of it. That's part of the case, but it's not the only factor in obesity. I think as people get to a point where they do have significant arthritic changes, that purely mechanical mechanism is more important, because now in those individuals that have some arthritic changes and that articular cartilage is broken down, it does turn into more of a mechanical issue, because we're putting pressure, a lot of pressure, on tissue that isn't really designed for that pressure. We're getting down to that bone level where bones aren't designed to slide and glide on each other very well. So that pressure ends up, the amount of pressure you put through there ends up really mattering. And so that's where, once people have arthritis, by losing weight, they can have a significant reduction in their discomfort. And when it comes to the knee, there's about every pound that you lose out of your body is about 4 pounds out of your knee when you walk around, because of the mechanics of how things are operating. So that's significant. But I think before arthritis begins, there's a lot of other mechanisms that are at play here with why someone that's obese has a higher risk for arthritic changes. And those mechanisms really come down to the fact that people that are obese have increased general body inflammation. And when we look at arthritis, osteoarthritis, really at its core, it's an inflammatory disease. So it's about how our bodies are able to handle inflammation, turn it over, and benefit from it, and not have a deleterious effect from it. And when people are obese, they don't have quite as good of a mechanism for that. Another thing when it comes to weight through a joint is body type, which I don't have on here, but body type is an important thing to consider. Putting a lot of weight through a joint, if that joint matches a body type that is designed to carry a lot of weight, like broad shoulders, big body type, big bone, quote unquote, right? Then that joint is going to be able to handle that weight a little bit better than someone that has a skinnier body type, more petite joints that don't have as much surface area. Then it's not going to be able to handle that extra weight as much. So someone that is really obese and has a small frame probably has are going to have a harder time with some arthritic changes than someone that has a larger frame, and they can handle that pressure a little bit more. So that's another thing that's important to consider, is the frame of the individual. The other thing that's really interesting with obesity specifically, not necessarily just body mass, but obesity, is that as our obesity increases, there is less reward for exercise. So our body works on a reward system. I'm sure you've heard, like dopamine, the endogenous opiates, endogenous cannabinoids, and things. Those some of those terms might ring a bell. Basically, those systems are all ways that our body has developed to reward us for certain behaviors. So in positive behaviors, so exercise is considered a positive behavior. The body has been designed to reward us for doing that positive thing. And however, whenever we become obese, those sensors that basically sense those opiates are not as sensitive. So we don't get as much of a reward for exercise. So this was kind of an aha moment for me as a physical therapist. Of course, like, I love exercise, right? So it's sometimes hard for me to understand why people just don't like it. And they don't like it because they don't have the same reward system that I have. I work out often, and because of that, I end up having a really in tune reward system when it comes to exercise. Whereas someone that doesn't wouldn't get that same benefit out of it from a psychological reward perspective. And you can even take that one step further, because eating operates on that same reward system as exercise. So if we're not as sensitive to exercise, if we're not as sensitive to our rewards with eating, then we're going to probably eat more to get that little bit of extra reward out of it. Because it's not that hard to eat, at least today in our day and age. It's not that hard to get, something that has a lot of potential, a lot of sugar in it, which gives you more reward, to end up with more, that little bit extra bump of dopamine, right? Same thing with being on our phones and social media. Those are all dopamine hits. So those are all those are quick ways to get that dopamine fix. Whereas exercising is a little bit of a harder way to do it. So if you're not as in tune to doing it that way, then you're going to end up probably not doing it. And when you do it, you're not going to enjoy it. And maybe something hurts anyways. So they say, why the heck am I doing this? So that's a little bit of an aside, but I think it's important to understand that we don't all get rewarded the same way, unfortunately. So that's why we all have different tendencies with respect to exercise. There is also a natural increase in full body, full system inflammation as we get older. Cytokines are one mechanism responsible for that, but it's important to just realize that maybe arthritis increases as we get older because there's a general increase in our body's inflammation. We're not as good at controlling it as we get older. Something that's been identified in the research often as a contributor to arthritis is weakness in the quadricep, which is that big front of the thigh muscle. Now, I have a little bit of trouble with this based on some other information that I've seen, and then especially my own practice, because oftentimes outside of the knee and hip arthritis categories, I see people that have other issues, and they're almost all dominant in their quadriceps. By that, I mean they prefer to use their quadriceps over their hamstrings and their glutes when they get up and go up and down stairs and things. And when we overuse those quadriceps, when we use those often, the joint that the quadriceps primarily controls is the knee joint. So then that knee joint ends up getting used more and more. And if now we're identifying people that have knee arthritis as having weaker quadriceps, I don't think it's quite as much an issue with the quadricep muscle specifically as it is the weakness in the quadricep can be used as an identifier for general lower body weakness more so. Because I guarantee, and I haven't seen any studies like this, but I guarantee if they took those individuals that had weaker quadriceps and then tested all of their hamstrings, their glutes, and all of their other leg muscles, those would be even weaker than the quadriceps relative to controls. So those muscles that operate the other joints are oftentimes even weaker than the muscles that operate the knee joint. So we need to understand, and this is something that I often use in physical therapy, is that when we're dealing with severe arthritis, we need to decrease that load through the joint, specifically that joint. So to take someone that has really bad knee arthritis and strengthen their quadricep, to me, that doesn't make much sense, because we're just adding load through that knee joint. And if we're trying to decrease load, then what are we really accomplishing? So that second bullet there, we need to understand the difference between a risk factor and a treatment. So a risk factor for arthritis could be a weak quadricep, though, as I said, I have a little bit of a disagreement with that idea. But the treatment, to me, is almost never to strengthen the quadricep, because we generally have pretty strong quadriceps. So we've got to worry about the other muscles in the lower body and the core. Getting a little bit deeper into risk factors here, we have to consider endogenous versus exogenous risk factors. So endogenous means things that are us, right? We can't really have a big influence on them. Our sex, our heredity, our age, post-menopausal changes, ethnic origins, those things are just there. That there are things, those things are things that can increase our risk for arthritis in the lower body. Ethnic origin specific to European ethnic origin, age, obviously, as we get older, sex, more common in males. So we can't do much about those, but some of the other risk factors here we can have an influence on, such as obesity. We can decrease our obesity. So gaining control of your diet, gaining control of your exercise regimen can help you reduce your risk for arthritis. Micro trauma versus macro trauma. Macro trauma is a little harder to have an influence on because those are like car accidents, bike accidents, falls, and things like that. That's a little harder to control. Micro trauma, you might be able to control that a little bit more. Those are things that end up like repetitive trauma through that joint, and you don't give it time to recover. So even just running, like overuse style issues, and you're not getting appropriate time to recover. The lifestyle risk factor there is typically they've identified alcohol use and smoking, tobacco use as increased risk factors for arthritis. And then a resective joint surgery will increase your risk for arthritis. My understanding, as best as I know, that we don't do these very much anymore. Typically those resective joint surgeries were specific to like a meniscus, where if we have a meniscus tear, they used to just take the meniscus out and say, all right, well, it's better because it's not there. But that actually increased risk for arthritis. So I think they've stopped doing a lot of those at this point. So moving on down the line here, hopefully everyone's staying with me. Arthritis, treating the uncurable and inevitable. So yes, arthritis is something, once it's there, it's not going away. Maybe someday in the future, we can develop some real true regenerative medicine techniques that help it go away, but it's not something that we can reliably say we can get to go away. But at the same time, it is inevitable. So it's going to happen if we live long enough. So is it truly an issue in and of itself, especially at those lower levels, those mild stages of arthritic changes? And I would argue that probably not. I would argue that if you take care of that joint and you take care of your body well enough, you could at least control it pretty well. Now, of course, I'm relatively young, so call me in like 30 years and maybe I'll tell you something different. But improving the health of our existing cartilage is something that is essential. So again, if we go back up to the top here, we have that joint here that looks pretty rough, and that is pretty rough. but there is some cartilage in there still, maybe over on that left-hand side, maybe a little bit over on that right. So we've got to improve the health of what we have. And remember, movement is nutrition. So movement brings nutrients to cartilage. Blood flow doesn't come to cartilage very much like our discs in our back, that doesn't get a lot of natural blood flow. So we need to enhance the health of our discs in our back through movement and our cartilage through movement. So nutrition is essential, and that nutrition comes through movement. Injectable therapies can also optimize the healing environment. So optimize the healing environment, what that means is, remember, it's an arthritis is an inflammatory condition, and inflammation in the joints is normal with movement, but the ability for things to heal and stop being inflamed is what is key to help enhance the health of the tissues and not degrade the health of the tissues. So if we use some of these injectable therapies, then we may have the potential to enhance that health by giving your body better control over that inflammation, by giving it an optimal healing environment versus, a lot like, so if stem cell is a great example of a therapy that years ago we thought we could take stem cells and inject them into the joint and they would become cartilage cells. My understanding of it, though I don't do it every day at all, I've never done it, but from what I've read on it and understand from talking to practitioners that do it, it's not as much, it's not that we think now that we're going to grow new cells based on those stem cells, but what it can do is optimize the environment for healing, to decrease inflammation and to help rebuild healthy tissue in there. Platelet-rich plasma, from my understanding, a lot of the randomized controlled trials of PRP versus stem cell injection tell us that PRP is similarly effective and much less expensive. So that's always a good option for the mildly arthritic joint, platelet-rich plasma, where they basically take the most nutrient-rich part of your blood and inject it right back into the joint. And then prolotherapy, oftentimes I don't think this is used in an arthritic joint as much as around it and in other tissues. But these are all operating on the idea of optimizing the healing environment and promoting the body's ability to heal itself. Decreasing in the inflammation and or pain. So we can decrease inflammation through our diet. That's important. I'm not a diet expert, so I don't think I can field many questions on that one, though it's always a hot topic. But it's something that we generally want to make sure we're not causing inflammation through our diet. And there's a lot of arguments within the nutrition world about what really causes it and what doesn't. But that's not a topic for me to cover necessarily. Medication. So you can use medication that can decrease inflammation. So your ibuprofen, your naproxen, those types of medications can technically decrease the inflammation, but we've got to be aware of the risk-benefit analysis there, because there's a lot of risks to taking those medications too, especially long-term. So we might not want to be regularly taking an ibuprofen for mild joint arthritis, because the risks of causing a GI issue and having significant negative effects from that are really there. So we've got to be aware there. Similar idea with the injectable therapies such as corticosteroids. Those can be really effective at decreasing inflammation, but there's a ton of risk there. One injection into the joint isn't going to change your life in a negative way, but multiple could have a negative effect on the cartilage of the joint. So you've got to be aware of, using one is probably okay, but as you go up and up in the number of injections of steroid that you get, you're going to increase that risk. Now, if you're going to get a joint replacement at some point anyways, then might as well go for it. Ride that as long as you can. But if you're trying to preserve the joint health and avoid an injection or avoid a total hip replacement or total knee replacement, then you probably want to put that off and hold off on the corticosteroids being used over and over again. Electrical stimulation is another great way to help address the joint pain. So just a regular TENS unit that you can buy on Amazon for like $30 can be beneficial at decreasing pain in a joint if it is really persistent. The third thing we want to consider is decreasing the load on the joint. So my most effective way in physical therapy to give long-term benefits is to increase the load on the other joints. So that means increase the load through the ankle and increase the load through the hip and the back and everything else. Distribute that lower body load a little more evenly, because like I said earlier, people generally use their quadricep too much. So if we take someone's load that goes through the knee and take 10% of it and put it in the hip and 10% of it and put it in the ankle, then that's a significant amount of weight reduction through the knee when we're going up and down out of a chair, walking up the steps. So train other joints to work better, enhance the strength of the muscles that operate those other joints, enhance your core strength so that you're able to balance out your body's ability to use different tissues and move in different new ways a little bit better. So that's a really, really key component of our rehabilitation process. Bracing can be super effective at decreasing that load through the joint. And it can also, we can't always look at bracing as something that is causing weakness in the tissue, because in fact, I've seen studies done where they brace the knee with just a neoprene brace. People have arthritis and they brace it with a neoprene kind of compression brace for a year. And one group wears it, the other group does not, and they test their quadricep strength at the beginning of the year and the end of the year, and there's really no difference at all between the two groups. So bracing alone does not cause weakness. It's more about a use question. So if you brace it and then never use it, yeah, that's probably going to result in some weakness, but bracing it alone does not. And then consider some low impact activities to be brought into your daily life if you do have some moderate to severe arthritis. So low impact, remember, the term impact is essential, not necessarily weight. So it's not low weight or no weight activities, it's low impact. Impact is really the thing that breaks down joint tissue. So it's those jumping and pounding exercises that if you have arthritic changes that are significant, you might want to try to shy away from those a little bit. Now, there are plenty of people out there that run or play basketball or ski or do whatever with some pretty significant joint arthritis, and they do it just fine. But that's the general recommendation would be to minimize that impact if you can, unless it's something you're absolutely really passionate about. Optimize self-efficacy. So one of the best determinants of recovery with arthritis is an individual's confidence in their ability to exercise and get benefit out of it. So if somebody just doesn't think exercise is going to help them and has never really exercised in their life and thinks this is stupid, I don't know why they sent me to physical therapy. The only reason they did it so I can check this box, so I can get my MRI and then get my total joint replacement, then I've got an uphill battle to fight with you. And it might not be worth fighting, and you might be right. Maybe this isn't for you, because the reality is if you're coming in with that mindset, then I don't know what we can do to convince you that it's going to be beneficial. But honestly, if you come in with a positive mindset and an understanding of what the expectations could be, we can have some great results with arthritis. It's certainly not the end of the road, that diagnosis of arthritis. But if it does get to the end of the road, surgical procedures that we have available are we have sort of three different procedures that I've seen done with respect to arthritis in the joint. First one being an arthroscopy. So that's the cleaning out of the joint. As oftentimes the orthopedic surgeon will tell you, I'm going to go in and clean out the joint. This I'm seeing less and less because the results aren't great long term. We don't have significant improvements with those arthroscopic surgeries for arthritis only. If it's a meniscus tear, like a traumatic meniscus tear, or ACL issues, MCL issues, those are good reasons to go into the joint. But truly just isolated arthritis, even sometimes arthritis with a medial meniscus tear that is a repetitive motion issue. So it's just degenerated over time to tear the meniscus. You want to think twice about those arthroscopic procedures also. Not to say you shouldn't do them, but you want to make sure that you're doing what you can to check all those boxes of making sure you've tried the conservative treatments before you go in and have that procedure done, because it's not without repercussions. Again, not that the arthroscopy never happens, but it's happening in my world. I'm seeing it less and less for the arthritic issues specifically. Resurfacing is a procedure that's specific to the hip. From my understanding, I've never seen it in the knee. I could be wrong for sure. But resurfacing is basically, I was told once, the analogy that, like, so if you have your hip, it's a ball and socket joint, and a resurfacing is basically you just put a new hat on the ball and a new little cup in the socket, versus the arthroplasty is you take the ball and you cut its head off and then you put a new head there. So you just put a little cap on that ball, then it can give you an opportunity to let that joint last a little bit longer, and it gives you the opportunity to have the arthroplasty or the total joint further on down the road. So this resurfacing procedure for the hip can be really helpful for people that are under the age of 60 that may need a hip replacement or have some pretty severe hip arthritis. That resurfacing procedure can help gain some years, because like I said, these tissues, these materials that we're putting into the joint, they just wear out. They don't recover. They just wear out. So they're going to kind of consistently wear out to a point where if you're 45 and you're getting a hip replacement, you're probably going to need another hip replacement later on in your life. So this resurfacing procedure can help maybe preserve that longer, because a revision of a hip replacement is tough, and a revision of a revision, I don't know if anybody does that. I've never seen one. But then if we talk about the arthroplasty, we can talk about like completely resurfacing complete new joints really for this, and we're getting down and putting a new anchor point in the bone, and we're anchoring that in. So that's kind of the big procedure, and it is a super successful procedure for arthritic changes, and it makes the pain go away. So often I rehabilitate someone after a total joint replacement, and they say, every morning I woke up and I had pain, and I woke up from the surgery and I didn't have pain. Even like the day after, like the day you wake up from surgery to be out of pain, that's pretty amazing. So it's definitely a successful procedure, and it's always worth considering. But I would say that we want to make sure we go through our due diligence to try to optimize the health of the joint that we have and the tissues that we have first, so that we make sure that we really truly need that surgery. Here's just some information about our clinics, where we're located. I put my email in the chat, and so feel free to shoot me an email and I'll be happy to respond. And now I guess we can open it up to questions.
I have a question. Oh, I'm sorry.
Hold on. Let's go with, I think, Phyllis first, and then we'll go to Mimi.
Okay, Dr. Gundling, I know that you're doing lower body joints, but I have two things that maybe you could discuss. Arthritis in the base of the thumb, in the bony deposits, whatever that is, and also the supplements of chondroitin, glucosamine, and collagen protein in helping any type of arthritis.
Sure. So the arthritis at the base of the thumb is another super common form of arthritis, and probably the one that I'm most worried about as a physical therapist, because I use my hands a lot. And it can be pretty debilitating, and it's something that develops, like I said, in people that use their hands a good bit. Something that you need to consider with that is, again, it's a similar idea that you need. There's a bit of an imbalanced strength at times, where that strength, you have more strength gripping, like making a fist, than you do have opening your hand. So if you can find a way to try to balance out that strength of opening your hand. So an exercise that I'll give people sometimes is to put a rubber band around their fingertips and extend everything outward. So extend those fingertips out so that you can strengthen out the outside of that thumb joint a little bit. And that might help with balancing that out. Another thing that's really helpful with hand arthritis is using like a paraffin wax bath. That can really help to calm down some of that feeling of pain in the joint. And then depending on how far degenerated the joint is, there's some other manual therapy procedures and physical therapy that we could try with it too. But then with respect to the glucosamine and chondroitin, really the studies that are out there on that says that when with respect to hip and knee arthritis, there is no clear benefit from taking it. But what I'll tell most people is if you have the expendable income and you're trying everything else, you're trying the stuff that we know benefits it, like exercising, moving, and good, generally a healthy diet, then adding that in isn't going to hurt much. It's worth a try because maybe it does work for you, but it's just something that I wouldn't hang my hat on it alone because it probably isn't going to help alone.
Okay. And the collagen protein, the same thing?
Yeah, I'm not as familiar with the collagen protein outcomes, so I can't really speak to them.
Okay,
Sorry.
thank you very much.
So I see Doreen has her hand up, but we're gonna get Mimi first, and then we'll go to you, Doreen.
Thank you.
Yeah.
Thank you. I have two quick questions. One is my understanding is that all joints can be affected by osteoarthritis. What about heel pain? Is that a symptom of osteoarthritis, or would that more likely be something like gout or something else? And then the second question I have has to do with squats. I do several exercise classes, and they all seem to concentrate on squats, which seems to me would strengthen your quadriceps. So what would be the opposite exercise of a squat? Since you're saying most of us do have, you feel that most people do have adequate strength in their quadriceps.
Yeah, great. Okay, so first question, I agree. Any joint can be affected by arthritis. Heel pain, not a super common cause of arthritis or a result of arthritis. Probably what you're looking at more there is, even gout, because gout and arthritis both affect joints, and there's not really a joint at your heel. There's a joint above and in front of your heel, but truly on that heel, you're probably looking at more of like a fat pad atrophy, maybe that your fat pad on your heel kind of developing a thinness to it, or some classic, like we call it, plantar fasciitis issues and things like that, or your Achilles tendon having an issue there. So I would say it's more like we would just generally classify it as a soft tissue disorder than like a joint disorder in that case. And that's where you could talk to, you could talk to a podiatrist or a foot and ankle orthopedic surgeon specialist, or, you can come to physical therapy without a referral as well, and you can have a look at it that way to give you a better idea. Then your other question about what I forgot, sorry.
Quadriceps and squats.
Yeah, that was a good one. That was good. I can't believe I forgot that one. So that's a great question. So all squats are not the same. All squats are not created equal. And generally speaking, I guess one thing that I don't want you to take from this is that quadricep strength is a bad thing. It's a good thing for function. But if your quads are weak, then that probably means your whole lower body is weak. It's basically what I want you to take from this. So yes, it's good. It's good to strengthen the quads. But if we're talking about squats, if we focus on sitting back into the squat a little bit more, like almost, I always tell patients, it's like you're sitting back onto a toilet seat. Like you kind of have to reach backwards. Then you're going to work on strengthening your glutes and your hamstrings a little bit more in that case than if you let your knees go way over your toes. You're going to work on strengthening your quads. So it's not to say that letting your knees go over your toes is absolutely wrong. It's just that if we want to bias some of the muscles that we typically are weaker in, sitting back is more helpful. So one exercise I give people a lot is to like go to your kitchen sink and hold on to your kitchen sink and sit back into that squat a little bit more and just feel how it feels to use those glutes, the butt muscles in the back of your leg muscles as you're deep into that squat. And that can be really helpful.
Thank you. That's very informative. Thanks very much.
Sure.
Doctor, what about walking and water therapy?
Bill, if you could hold on for 1 minute, I think Doreen had a question, and then we will go right to you.
Hi, thank you. This has been really helpful. My mother took tetracycline when she was pregnant with me back in the 40s, and that has had some medical impact on me. But I have osteoarthritis in every joint in my body except my skull. And I'm wondering whether the tetracycline, I've wondered this for a number of years, might have had an impact on that. I've had a great toe, a left knee, and a left hip replacement, and my other knee and hip need replacement, but not right away. But my hands, I have no cartilage in my elbows at all, my toes. And so, I wondered whether that tetracycline, I don't know if you know anything about that aspect of it and whether that might have had an impact on what's happened to me over the years.
No, unfortunately, I don't. I'm sorry to hear all that, but that's kind of beyond my understanding of it all. But if you could shoot me an email and just to remind me, I could look that up and see if I can find anything real quick about it. But that's beyond my understanding.
All right, thank you.
Yep.
Okay, Bill, if you want to.
Doctor, what about walking and water therapy for low impact activity?
Great. Yeah. So aquatic therapy is really helpful. We actually have a pool in our Murraysville office for that specifically. So aquatic therapy or going to the Y and using their pool can be helpful because we're decreasing that impact. And walking is great too. Just the biggest thing to remember is I hear this all the time. People say like, yeah, I'm really active, I'm healthy. And then I ask them what they do. And they said they walk and they walk that like 10,000 steps a day and they're proud of it, which is great. But unfortunately, that's not the whole ticket. And strength is so important. So while walking is helpful, keeping, when we walk, we basically just walk in one direction, straight ahead, and we take little steps. So we've got to add more variability. I mean, think about how our bodies were designed: hunter-gatherers, running, jumping, rolling, all these things. Not that you need to run out and do that, but our bodies are designed to take loads in different planes of motion and change directions and things. So just walking down the road isn't going to quite do it. So strength training is super important. And I have a talk that we've done previously about strength training and how important that is. And I don't know if it's still posted. Corey could probably tell you, but that might be worth revisiting, or maybe we can do it again too. So yes, that walking's great, but strength training is really, really good.
Thank you.
Another hand up. Amy, did you have a question?
Yeah, I have a quick question. Is it osteoarthritis where it moves from joint to joint? Like one day your left knee hurts, a week later it's your right knee, your hips hurt off and on. Is that osteoarthritis or is that a different type of arthritis?
So that's probably a different type of arthritis. Although you can have, like, if you have osteoarthritis in those joints, one might hurt one day and one might hurt the other, but it's not like it goes away from that joint from day to day. So it's probably more so, it could be like the gout, or it could be some other rheumatologic disorder. So in that case, you would want to talk to a rheumatologist, and they would be able to do some blood work and some diagnostics.
Okay, thank you.
There's a question. Do you do prolotherapy? Would you explain it? So no, I don't do it. But prolotherapy, the idea there is you basically take a sugar solution and inject it into some of the pathological tissue. And the idea is similar to exercise. When somebody comes in with an injured tissue, and more often I'll see this done in like tendon or muscle or even ligament tissue than like a joint. So like I said, prolotherapy isn't super common in a joint, but when someone has had an injury to a tissue, there's a certain inflammatory process that occurs. And if it doesn't fully heal during that inflammatory process, then we end up kind of with a non-healing effect. Sometimes by exercising that tissue, we can kick off that healing cascade again, and it will get better. But another way to do that could be through prolotherapy by injecting this sugar solution that causes inflammation to kick off that healing cascade to push it through all the way through to its endpoint. So with prolotherapy also, like exercise afterward is very important to help new fluid flow through and back and forth in there.
Okay, does anybody have any additional questions they'd like to ask? I see Mimi has her hand up.
Yes, do you look at homeocysteine levels when you're evaluating the general inflammation process in an individual, or are you not concerned? Are you looking really at the physical effects of inflammation as opposed to worrying about the lab values that indicate it?
Right. So, I mean, from my perspective as a physical therapist, it's not going to drive my care one way or another. So I don't oftentimes look at it. However, like, talking to, for something like that, I would recommend talking to like a physical medicine and rehabilitation physician, or also known as a physiatrist, and they could work you through that, because then they could actually prescribe medication for that. And as a physical therapist, I can't prescribe medication. I can just prescribe exercise. So that's something that's kind of outside of my realm anyways, but those are important to consider, right? And that's something that, talking to someone that has the ability to manipulate those a little bit more would be great.
Thank you.
Mm-hmm.
All right, any others? You can speak up or raise your hand. Okay, then I think we will wrap things up for today. As a reminder, this should be posted to our YouTube channel and our Facebook page Wednesday night. If you'd like a copy of the handout, you can email Dr. Gundling or myself, and we should be able to get one to you. Thank you all for joining us. We will be having another session on Monday, April 25th, same time, 2 p.m. online, that will deal with osteoporosis. And if you have any questions about that, feel free to email one of us as well. So, thank you very much for coming today, Dr. Gundling. It was great as always.
Thank you very
Thanks,
much.
everyone.
Thank you. Thank you.
Thank
very much.
you.
Goodbye all.